Welcome, everyone. My name is Brea. I am with Gentiva Hospice. I am presenting from my car today, so I do apologize about maybe the background. I have been with Gentiva Hospice for a little over 7 years now. We were formerly Kindred Hospice. Prior to my stay at Hospice Services so far, I was a director of memory care, as well as a prior admission director and activity director. So I've certainly seen a variety of different locations, as well as patients as they navigate their journey towards life, essentially. So today, our really focus is just talking about how seniors can essentially age in place and the levels of care that are offered either through private pay, insurance, or in certain types of benefits that Medicare does allow for insurances. So the four main groups today that we'll be talking about is home care agencies, home health services, palliative care services, and then hospice services. So we'll kind of just dive in and talk about the beginning levels of services that are offered. Again, if you do have any questions throughout the presentation, probably just easier to throw them into the chat box here. That way we certainly can make sure that those get answered. And then we can always circle back if something needs to be brought up. So again, we're going to talk about the four main levels of care that typically we see as seniors start to go through the aging process. So the first service that typically is recommended is a home care service. Now, home care and home health definitely sound very familiar, so I want to make sure to definitely separate the two of them. Home care agencies are considered a non-medical service that helps seniors typically in their home setting, assisted living setting, possibly a skilled setting, and they're helping with activities of their daily life. So maybe that's dressing, maybe that's medication assistance, maybe that's a ride to the grocery store to help with grocery shopping. Maybe that's light housework. So anything around the house that they could be helping the patient with that maybe they just can't complete on their own. So really helping with that lighter level of service. Again, it's considered non-medical because those staff aren't necessarily providing medications for the patient, recommending certain levels of care. Although they might just be assisting with that care, it still is considered a non-medical type services. So that is a private pay services. Some of these home care agencies will accept a long-term insurance, but for the most part, it is an out-of-pocket cost, a private pay that they would charge a certain rate based off the need for that individual. The nice part about home care agencies is that they can start as small as a 15-minute increment where maybe they just need someone to do something very quick at their home, or maybe just a quick ride or a quick shower. But then they can maximize these hours all the way up to 24 hours a day, including a live-in caregiver. So it's really going to depend on what that patient and individual's goals are and care needs are. So a lot of times we'll see agencies start with maybe a couple hours a week, and then as the patient unfortunately declines or goes through some hiccups, they can increase that visit frequency and hours for that caregiver that they have. So it's important to work with that agency to let them know, what they're predicting. You can combine home care agencies with any other service that we'll talk about today, because this is the only service that we will talk about that is the private pay. So it's not necessarily covered by insurance. So that allows it to be partnered with multiple services potentially at a time. So A lot of times when I get the question about home care agencies, typically it's how much do they cost? And each agency is going to vary in what the cost is. Some of those factors might be if they have a caregiver on staff versus if they have a licensed CNA working for them. So that might be the difference of what a cost would be per company. But certainly is important to interview multiple companies to see what their daily rate is or their hourly rate, and ask some of those critical questions. Is it a caregiver? Is it a licensed CNA? And maybe that might fit what the patient's needs are a little bit better, or as they decline or need further assistance, maybe they do truly want a CNA versus a caregiver in that sense. So certainly, it's a very nice light starting service to have because it helps the patient with non-medical needs as well as some light things that the patient might need just for activities of daily living. So that is home care agencies. There's many companies actually that we work with in the Chicagoland area here. If you need recommendations for any companies that I personally have worked with in the past, maybe we could take that offline just so I'm not heavily promoting one company over the other. So with that. So that is kind of what home care agencies look like in a nutshell. Now we're going to flip over to what we classify as home health services. So home health services are classified as physical therapy, occupational therapy, speech therapy, or a skilled nursing need that they might need inside of their home. Maybe that's catheter care, wound care, anything that requires more maintenance in the home versus an assisted type setting or what's the doctor might be recommending for them. So this level of services, again, is a skilled licensed person coming in providing physical therapy, occupational therapy, or speech therapy. And that is billed through their insurance. So insurance will essentially grant them a number of episodes based off what has happened. So a lot of times when home health is referred, it's typically triggered by maybe a fall or a hospitalization where a provider or a medical director is recommending that they need follow-up after the incident. So they will refer to a home health company, and then insurance will really help monitor what the progress is for those patients based off what their need is and how they're doing with that. When you're on home health services, you can get physical, occupational, and speech therapy, or even that skilled nursing need kind of all lumped into one. Or you could specifically be on home health services for just physical therapy. The home health services that I'm specifically referring to with and that we work a little bit more is therapy that's provided inside of the home. So it's classified as Part A therapy because a lot of times we see therapies that are at an outside location, maybe your ATIs or something like that, where people go to get routine therapy. You're always going to start at least with the senior population on the Part A therapy because that's provided more in the setting that that patient resides in. So they're really helping the patient get acclimated back to their home, maybe where the fall happened, making sure that they know that the light switch is on this side, doing safety checks for the rooms, and providing the care in their home there. If they ever get discharged or once they do get discharged from that Part A, then they would go to a Part B therapy, which is more of your outpatient therapies. And that is more of a maintenance type therapy. It's not as aggressive therapy as Part A would be, which is what they first get when insurance issues those allowances of therapy dates. Again, like I said, it's heavily regulated by the insurance company and the progress that the patient is doing on that services. So a lot of times patients will be seen once, twice, maybe even 3 times a week for therapy. Again, really depends on each scenario. And then the insurance kind of reviews that each week to see if we're doing good with that. Do we need less visits? So hard to kind of manage with insurance company these days. But that provider would certainly give you the allotted dates and keep you posted on what is needed for that. Um, With home health services, you can combine that with the prior service that I talked about, home care, because they're providing more of your activities of daily living. This is a licensed therapist coming in helping with the patient. You can also combine home health services with palliative care services, and that's the next topic that we'll talk about in just a few minutes here. So you can kind of combine the services with other assisting factors if they're in that home setting there. But you'll see many patients that have home health services. Again, usually the cycle goes that they have a fall or an incident that triggers them to go to the hospital. It's designated that they have therapy for kind of the follow-up or their care plan discharge. And then basically that cycle can repeat at any time if they have another fall or an incident where they need to go back to the hospital. That's when insurance would review it for additional type visits or if the scenario was different. So it's kind of like a cycling pattern for home health services. So there's not necessarily a cap on it, but based off the person's insurance, there could be. So with that being said, sometimes you'll see if a patient does have that fall, they'll might be transferred to a short-term skilled nursing facility, which is where they'll be providing more aggressive therapy inside of the skilled community to get the patient's goals to go back home where they can be more safe in their home environments. So a couple different options that you could see triggering the home health, which also kind of filters into the skilled category, or if they go to a short-term rehab, which is more aggressive therapy in the building there. So like I mentioned, it is all covered underneath insurance. They do dictate a lot of it. Specifically, it's billed under Medicare Part A for their insurance. And that allows them to have a secondary services on Part B if that is needed. So. A doctor does need to order physical therapy with the services. So a doctor would need to order that. If they did need any additional equipment or adaptive devices in their home, the doctor is still writing an order for an outside company to fulfill that need for that patient based off what their needs are. So doctor driven, insurance driven for this specific level of care. So as we kind of jump down the levels of care, so we've got your home care, we have your home health services. Now we're going to jump into palliative care services. Palliative care services often gets intermixed with hospice services, and there is actually a very big difference in the level of care that is being offered. Palliative care is specifically where patients have a life-limiting illness, a life-threatening illness, or chronic comorbidities, but the patient is still wanting to seek aggressive routes of care. So specialty doctor's appointments, hospitalizations, chemotherapies, surgeries, if that's an option for them. They're wanting to pursue aggressive treatment, but they do need some expertise or some follow-up after these episodes. So a nurse practitioner is assigned to these patients that enroll in palliative care or it's being recommended. And that nurse practitioner is helping with the follow-up. So they're helping with symptom management, they're helping with pain management, they could be refilling prescriptions, they could be seeing what's the difference from the patient after the treatment and how their side effects are in the home. So they're really kind of that light monitor of after the treatment has been performed and how the body is reacting to it. Their visits are a little light. They're doing a visit typically one time a month. So once every 4 weeks, that nurse practitioner is following that patient. Most of the time, they are in more of a home setting, so a residential home, independent living, assisted living is going to be where the main places that you see palliative care, but it can be performed in a skilled nursing home. It's just not as common there because they have nurses and doctors that round there on a daily basis that somewhat could already provide a palliative type care in the model that that facility is doing. So a little bit more popular to see them in a home setting or assisted living or an IL setting. That's a little lighter where they don't have 24-hour nurses, for example. So that nurse practitioner during her visit is doing essentially a mini doctor's appointment for the patient when they're in their home setting, really help monitoring their symptoms that they're having, their pain management, and they're taking all of that information and reporting it back to their primary care or their specialty care doctor that referred the palliative. So next time that they come into their doctor's appointment, they have a lot more to work with versus how has the last few months been. So it's very helpful for that doctor to have that follow up in the meantime. If that nurse practitioner wrote any medication orders, if they complained about pain, if a new series developed during or after that treatment that they weren't aware of, they have that information and tool to work with to better care plan for the next month or 2 months, whenever their next appointment is, to see what they can be doing in the interim of that. The nice part about palliative too is you can combine it with both the services that I've previously talked about. You can combine it with home health services so the patients can still continue with physical therapy while on palliative, occupational or speech, or that skilled nursing need while still on palliative services. Because the services are so light with palliative, it allows them to still have that physical therapist that might come twice a week, that occupational therapist that might come once a week in the interim. So the palliative NP is still communicating with the home health team that's on board, again, to get the full picture of the patient. And again, if that patient needs services outside of that, they could still have that home care agency that's helping them with light housework, rides, non-clinical care. So it's a nice multiplication of services that you can combine it with. Palliative care is specifically billed under Medicare Part B. They also take a variety of insurances as well. And some providers do take Medicaid as well. The tricky part is that each palliative care agency is going to have providers that they are in network with and then providers that they are not in network with. So that specific palliative company would have to run the patient's insurance just to check to see what type of benefits that they have. It is also very common for there to be a copay with palliative care services. Most of the time it's around a 20% copay. But again, that is going to be based off that individual's insurance and the provider that they have selected. There are times where a palliative patient could not be accepted to palliative care services. Maybe it is a lifelong issue that they've had because our palliative team doesn't specifically deal with chronic pain that they've had for their entire life. So the NP still does go out to do an evaluation for services and declares if the patient is eligible to participate under the benefit for palliative care services. So again, they're always doing that evaluation to make sure that they're clinically eligible and kind of what that looks like. The nice part about palliative care services too is that patients can stay on this service essentially for a very long time. There is no essentially cut date for them or discontinuation of services. Essentially, it's really when that patient has either met their goal and they don't think that they need that service any longer, and or maybe the patient unfortunately has declined and needs a higher level of care. So most patients can stay on palliative care services for many years, and they do stay on it based off their treatments or what the doctor is recommending as well too. So a couple different thing with that. Anyone can essentially refer a patient to palliative care services as well. They could inquire about it. It doesn't have to be necessarily be a doctor. It could be a family member. But the doctor does typically have to write an order for palliative care services to be evaluated and or come out for that. So again, kind of doctor driven, doctor overseen, because it's their patient that they're trying to find a cure for and or keep their symptoms comfortable with. So. Perfect. So we will go on to hospice services, and this is actually the service line that I work with the most, being with Gentiva Hospice. So with hospice care services, I know that the H word has a lot of stigma with it. So I often refer to hospice services as comfort care, essentially because that's exactly what we're doing, and that's what the family or patient has elected in this stage of their life. So when a patient patient chooses comfort care over curative routes of care is typically when hospice is referred. There could be multiple reasons for this. Maybe there is no cure for the patient. Maybe the patient has been attempting curative routes of care and is simply tired of being poked and prodded essentially and wants to focus on the comfort and quality that the patient has however long they have left on earth. So there's multiple reasons why a hospice referral could be sent or recommended for a patient, but ultimately that patient or that POA has to agree that curative routes of care might be too aggressive for the patient at this stage in their life. So when we talk about comfort care services, again, we're removing those more aggressive type treatments. So when a patient elects hospice services, we're typically discontinuing hospitalizations, specialty doctor's appointments, physical therapy, the service I mentioned earlier. They do discontinue palliative care services. So it allows the body to ultimately have more comfort and quality versus continuing to go to doctor's appointments where maybe there's really no treatment for the patient or it's too much for the patient. So a lot of times with patients with that, we're removing those more aggressive type treatments, but hospice doesn't discontinue all types of services. So we'll still be able to treat what we consider a lot of minor episodes wherever the patient calls home. So we'll still continue to treat episodes like if a patient develops a UTI, pneumonia, sometimes COVID. So we're just not getting a lab test to test if they see if they have these things. We're going to proactively treat based off the symptoms that the patient is presenting. We're very much in tune with the family when these smaller episodes come up so they know, but we're able to just proactively order the medications because we can do that in more of a home setting for the patient versus, again, sending them out to the hospital to be tested for a UTI and then sending them back. We do all of that right at the facility there. So again, we're removing those more curative routes of care. We're focusing on comfort. Hospice is the highest level of care you can get under Medicare, Medicaid, or even Medicaid pending. And essentially almost any insurance plan should have a hospice benefit built into it as well. Most of the time when we're looking at hospice patients, they are typically 65 and older because they're on Medicare, but that's not always the case. We've had many patients that have fallen underneath that 65-year age mark, and most insurance plans will have a hospice benefit built into it, but there might be a copay that the insurance requires if they go on hospice services. So that's the nice part is that we really can take almost any form of insurance because it's a benefit designed for all aging seniors or people towards what we view end of life care. So that takes a little bit of pressure off if they're accepted or not into it or how much care they're provided because it's the benefit built for all people towards what we view end of life care. Like I mentioned earlier, hospice is the highest level of care you can get. Unfortunately, it is more of a standalone service. The only service that you can combine with hospice service is the first service that I discussed in the presentation, which is your home care agencies. Again, the non-medical care, helping with, housework, medication reminders, getting dressed, like those type of things. Because hospice is a billed under Medicare Part A, and the other services that I've mentioned are more curative routes of care versus comfort. With our hospice team and the benefit, we have a large team that follows each individual patient on our service. So the first and foremost, we have an RN, a nurse that would come to wherever the patient calls home. And they would do essentially a head to toe visit during a head to toe examination during their visit to really take and see what is going on with the patient. What are the declines? What are we worried about? What are the goals for the patient? So I almost call it like a mini doctor's appointment each time they're there versus going out to the physician. That nurse is coming right to their home, helping examine the patient, helping get what they need on board. So they'll handle wound care as well. They'll handle any declines. They'll handle feeding declines. They'll handle just general declines with the body. And they're doing that visit in person. And then they're also communicating with a hospice medical director behind the scenes to help write orders for the patient, help with next steps. So a doctor is always still involved in the case, but most of the time they work behind the scenes, and the hospice RN is doing the majority of the hands-on work for our hospice patients. The variety of visits that the patient can get through nursing can certainly vary, depending on when the patient comes onto hospice services and where they're at their journey will depend the visits that the patient essentially gets. Specifically with our company, if the patient is more stable when they come onto services, we always offer a minimum of twice a week for a nurse to come out and have that appointment with the patient to just help monitor them more closely. If the patient comes on and we're a little bit worried about something or they're having an episode, they could routinely be seen 3 times a week, 4 times a week, but we can dial those visits all the way up to 7 days a week. So I always say our nursing visits are going to be based off the clinical care need for that patient at that time, knowing that it can change quite frequently as well too. So the nurse will kind of designate how many visits that patient should be seen, and we can help follow through with that. The hospice nurse, we always have one on call 24/7. So it might not be the routine nurse that would see that patient on a weekly basis, but we do have a night nurse that comes on as well. So that makes us available for 24-hour emergencies, 365 days a year for any of our patients. So that is the nursing component of it. We also have a hospice aide that will help the patient with, again, activities of daily living. So showering, toileting, dressing, feeding assistance, anything kind of to get them up and get them ready for the day is when you would see most hospice aides in the community. A lot of patients are a 2-person assist. So the hospice company is offering that one caregiver to do the majority of the work. And sometimes we will use a facility staff member there or possibly a family member inside of the home if they need to be transferred into a bed to a wheelchair, for example, and they need a 2-person transfer support and or a Hoyer lift for that. So the hospice aide helps with a lot of those things. Again, the hospice aide visits, if patients are more stable, they'll typically come on an average of 2 to 3 times a week for patients based off their current shower schedule. But those visits, again, could be increased all the way up to 5 days a week, depending on the clinical care need for that patient. Patients that typically have an aid issued 5 days a week are typically considered bedbound, unable to feed themselves, incontinent of bowel and bladder. So they just need general overall more care than some of our other patients on service. So we have the capability for nursing to go all the way up to 7 days a week, and then a hospice aide all the way up to 5 for the Monday through Friday. Additional services that we offer for the patient would be a social worker for each patient as well. The social worker will help with a variety of different components. So they're looking to see, is the patient a DNR, a do not resuscitate? In the state of Illinois, we do not require hospice patients to be a DNR when entering onto hospice services. It does somewhat conflict the care that we're offering because we are offering comfort care. If a patient is a DNR, that does require the staff that is at that facility or possibly a family member to call 911 to help if a patient starts to code. So we do provide a lot of education on what a DNR is and then the different options that are on a DNR. There is an option for a straight do not resuscitate. There is an option for a DNR with selective treatment and a DNR for comfort measures. So the social worker takes the time to go over and explain what those specifically mean, as well as what is best for their loved one. A DNR can change. So just because a patient signed one 20 years ago, it doesn't mean that they need to still abide by that current document. As long as they fill a new one out and a physician signs it, they can update their DNR to their preferences in present day. The social worker will also help with a variety of resources if they do not have a funeral home on file or they don't know what they would like to do for end of life wishes. That social worker can present certain options that loved ones have at the end of their life. The social worker will also do companionship visits for the patient. So they will join them for maybe an afternoon or sometimes during a meal to help conversate with them and sit with them, help engage in conversation, etc. As much as the social worker does care for the patient, we understand that the family member is equally, or the family could be equally struggling with the decision to go on hospice and maybe the changes that the patient are having. So we do offer support for all of the family members as well, included in our benefit. So sometimes family members live out of state and their loved one is here in Illinois, for example. So we're helping just communicate maybe the difference of what's going on with care, or if they have questions. Sometimes there's one sibling that doesn't agree with a certain medication or something that was prescribed. So they are essentially kind of a peacemaker within the services as well, too. And then we have chaplaincy services as well. A chaplain is also assigned to each of our patients. A chaplain can help with any type of spiritual needs. All of our chaplains are considered, and most are considered non-denominational, which allows them to cover a variety of different religions. And they simply can engage in as much or as little prayer as that patient or individual wishes. A lot of times they will do scripture readings. Maybe they will do a blessing of the hands. They'll engage in life conversation. So many different options that our chaplains can offer our patients. They'll do companionship visits as well to spend time with the patient. If there is anything that the patient or family is requesting that our chaplain does not do, we do partner with local priests or parishes in that area where the patient lives for a patient maybe to have last rites, maybe to be anointed. So that chaplain certainly works or supplement visits if there's already a current priest or pastor already involved in the care. So definitely a nice additional service to get more often as well, too. So those are the four main disciplines that the patient will see on a weekly or essentially a bi-weekly basis. So the nurse case manager, again, visits could be all the way up to 7 days a week based off the clinical care. Hospice aide visits based off clinical care can be seen up to 5 days a week. Social worker, typically they come about twice a month. However, again, if a patient is not a DNR or there's questions or maybe some family issues, that social worker could come weekly at that point as well. And then chaplaincy services usually are about twice a month. But again, if we have higher spiritual needs, we can pull them in for weekly visits or more as well. Again, we always have 24-hour nursing services and support for any emergencies that happen outside of the workday. I feel like most of them always happen after 5 o'clock as is. So that support for the patients. The hospice benefit also includes a lot of extra stuff as well, too. So when a patient is referred to hospice, our nurse will do what's called a hospice evaluation to make sure that they are clinically eligible for services. 2 physicians have to agree that a patient is eligible for hospice services. So maybe that first order would come from their primary care doctor, maybe the doctor that they see in an office. Maybe it's a doctor that is rounding at the community that they reside in, and they're recommending that we take a look. So our hospice medical director reviews the case after our nurse evaluates and basically agrees or disagrees with the current physician that wrote that order to see if the patient is eligible for care. Since it is Medicare regulated and there is so much included in this benefit, they are looking for quite a few things for a patient to be eligible for services. The patient has to have a 6-month or less life expectancy based off their diagnosis. But with that being said, we also do not have a crystal ball on when patients will expire. So the doctor is making an educated guess, essentially, that a patient could pass within this time period based off of their current diagnosis and symptoms that they are presenting. So there's a couple factors that go into that. And I will talk about in a moment the benefit periods that a patient could go through with that. So a patient has to be eligible for hospice services in order to come on. That nurse does the hospice evaluation to make sure that they're clinically eligible for services. And they're really looking at what is the difference for this patient. Typically, we use a 6-month benchmark. So how was the patient 6 months ago to how are they presenting present day? And sometimes those declines happen within, well, 2 weeks ago he was doing this and now he is doing that. So any kind of time marker in that 6-month period is fine. Maybe they were ambulating with a walker and now they are completely bedbound. Maybe they have lost 10 pounds in that time frame. Maybe they were recently diagnosed with a cancer. So we're really trying to, unfortunately, pull out what has been the negative effect on the body in order to qualify them for that service. Once they are approved for services, the patient can come on to our services and start receiving all of the care that I have mentioned. Included in all of those visits is we would also provide any medication related to the patient's terminal diagnosis. So if the diagnosis was a heart failure, we would be able to provide medication specifically that the patient might be taking around heart failure. Our nurses will also do what's called a med reconciliation. So if they are currently taking other medications, we just see if they can continue with those, if it's covered underneath the hospice benefit or not. Most of the time, medications are covered, but sometimes if they're a very far left or a far right medication, our physician might recommend that we don't continue with it, or maybe the impact on it at this stage in their journey is just not helpful. We always bring something on for pain measurement as well. So the nurses will typically write a PRN or a scheduled medication for that patient right away to make sure that we are keeping them as comfortable as possible. We will also supply any durable medical equipment that the patient might need, again, which in whatever setting that they're in. So that could be a hospital bed, a walker, a wheelchair, a fall mat, a bedside commode. Again, anything that really helps them with transfers, comfort, mobility. We're looking at providing those things and swapping out maybe the current equipment that they have. If they just have a bed that they put together themselves, we might want a hospital bed that goes all the way up and down for ease of transfers or changing the patient. So all of that is included underneath our benefit. And then we also cover incontinence supplies for the patient if they're incontinent of bowel and bladder. We order on a weekly basis, and those products would be shipped to the patient's home or facility and brought to their room. So those are things that are additionally covered underneath the hospice benefit as well, too. A lot of other companies do still have some what we call the extra things. So with Gentiva, we have pet therapy. So a lot of the communities or homes that we go to, we have certain pets that are in that area, and they could get the experience of pet therapy as an additional service. We also have massage therapy for patients that have a certain diagnosis to help with tremors or tightness in their body. So a nurse does have to assign them or write an order for the massage therapy, but we do have the capability to work with that. Some of our patients are seen weekly for that extra bonus. We also have volunteer services as well. Our volunteer services are non-medical, so they can't necessarily help with direct care, but they certainly can help with a game or an activity, maybe run to the grocery store for the patient and collect some items. So it's really up to that volunteer of what we have assigned to them and what the capability they would like to do with the patient. But we do offer those services. Gentiva itself does not have a designated music therapist, but some hospice companies do. We really fulfill that benefit with some of our volunteers. We do have some volunteers that play music for our patients. So we kind of do a 2-for-1 with that they get the volunteer experience, but also get the music with it. So those are some nice added bonus things that you might see with hospice companies in the area as well, too, with that. Again, I know we are covering a lot today. So I just kind of wanted to finish with the benefit periods that hospice can offer. So as I mentioned earlier, when a patient comes onto our service, they are issued what's called a benefit period. Because hospice is viewed end-of-life care, we need to monitor how long they're on our services and if they still have a 6-month or less diagnosis for the terminal illness that they have. So when a patient admits to hospice services, they are issued into their first benefit period. period, which lasts 90 days. And then every 60 days after that, so after the 90 days is up, they will go to a 60-day benefit period. And essentially, the physician and the nurse are reviewing that patient to make sure that they are clinically eligible for services. So they'll keep repeating those patterns until we get to that 6-month mark. And when we get to that 6-month mark, if they still have declines or they still are losing weight, maybe they have UTIs or falls in between that typically research them for another benefit period on service. So all patients that are in hospice go through these benefit periods just to ensure that they are still medically what we view towards end of life care to receive all of the extra services that hospice is offering. We do have some patients that do what we call graduate off hospice services or are discharged because of extended prognosis, which simply means that patient and the doctor and nurse don't believe that the patient will pass within the next 6 months because maybe they have gained weight, they are talking more, they haven't had falls, they're improving in their overall condition essentially. So a patient could be graduated or discharged off as hospice services because of those reasons. But at any point, a family can always revoke our services and discontinue hospice. Maybe it's not what they expected. Maybe they want the curative routes of care. Maybe a surgery was offered to them and they wanted to elect that surgery. So the family and the patient is still always in the driver's seat. They always get to make these decisions. And we simply can help provide education and they could discharge off of our services. If a patient does discharge off, they are always welcome to come back to our services. Maybe they had a hospitalization and a surgery was presented. They had that surgery, got home, and then saw some more additional declines with the patient. They could call us back and explain what happened, and we could come out to essentially reevaluate that patient to make sure that they are still clinically eligible for services and resume with hospice care. It is a little bit of paperwork for the family. Each time a family does sign or come on to services, they do just have to sign consent for care, which would be our consents for hospice services. Again, Medicare regulated. So, and I'll just add, a lot of the times we see the patients kind of project in the order that I presented the services in. A lot of times we'll start off with the home care, maybe have home health with it. Maybe they will have a little further decline or unfortunately be diagnosed with a life-limiting illness and elect for palliative care services. And then unfortunately, again, as we see patients need more care or have a decline, then we see them more at the end with hospice care. But it doesn't necessarily always go in that order, though. Sometimes hospice is recommended as an early benefit for the patient, and maybe they get better on our services and can discharge off and go on home health services. So it's not necessarily a one-way street. It certainly can be a two-way street and kind of take turns with different support of the care that I have mentioned here. So while we typically see the natural decline be home health, palliative, hospice, it doesn't always happen that way.